Thanks again for continuing with the ACCS exam review. This particular module is focused on an overview of endotracheal intubation and managing a difficult airway. And I may have said this elsewhere in this presentation, or in this session, but the exam matrix for the ACCS exam starts off with airway management. So it's the first section. Doesn't mean it's the most important section, but it's the first section there. So let's look at learning objectives for the next about half an hour. We're discussing the indications, contraindications for intubation or putting an artificial airway in place, recognizing some different strategies that we can use to help recognize a difficult airway in anticipation, special considerations for managing a difficult airway, related equipment, so laryngoscopes, intubation box, sizing of ET tubes and LMAs, a little bit on difficult airway box. Many places are instituting that. Key steps in the procedures, key steps in confirming placement, measures to consider if confirmation is in doubt, and then some wrap-up points and some related references. So indications for intubation, hypoxemic and or hypercapnic respiratory failure, a prohibitive breathing pattern, prolonged tachypnea, inability to protect the airway, and severe and worsening respiratory muscle weakness. Contraindications, the presence of a DNI or do not intubate order, laryngectomy. If you recall, there is no, if you will, patency or opening between the mouth and the trachea with a total laryngectomy. Epiglottitis, it means you could still intubate, meaning the patient can still be intubated, but it probably should be done under very controlled circumstances by an anesthesiologist, and they may ultimately require a rapid sequence, paralytics, analgesics, the whole ball of wax there. Tachypnea due to anxiety and or pain. So it's tachypnea that's not really of respiratory etiology. Treat the anxiety, treat the pain, and the problem, at least for the short one, goes away. Related equipment, what you need in the room. So you need your protective equipment, your manual resuscitator, ambu bag, age specific, of course, oxygen flow meters, suction source that includes the tubing and the yank hour. I remember I was orienting a new graduate. I was in the surgical ICU where I was once the lead therapist. And I remember I was getting ready to intubate the patient. And I said to him, he was a nice guy, very nice. I'm sure he has grown up to be an outstanding respiratory therapist. And I said to him, so-and-so, can you get me a yank hour? And, really what I meant was, can you get me suction, the yank hour to tubing? And he handed me a yank hour. It wasn't connected to anything. So it's not funny. Everything went okay in the long run. But I said it to my then manager. I was just recounting. It wasn't bad mouthing the guy. It was guy said it with a smile on my face. And my manager looked at me and says, well, you asked for a yank hour. He gave you a yank hour. So I'm like, yeah. So in any case, suction source, tubing, yank hour, etc. End-tidal CO2 cable and adapter. At a minimum, a coloremic detection device. Difficult airway box, hopefully located in each unit. I will say difficult airway boxes are pretty much becoming the standard of care. The anatomy of an intubation box, yes, they vary a little bit place to place. What I do is, if I'm even like tomorrow and Friday, I'll be with students at Morristown Medical Center, where I also work. And if we either do assist in or we witness an intubation, before they take the intubation box away and they send it to central supply, we look through it and I try to either, whether it's students or orientees, I say, become familiar with where things are located in these boxes. You'll be assisting with intubations, and it's critically important that you know where the stylet is located, where the suction is located, where obviously the tubes and the syringe, all that stuff is located. The LMAs, we do keep LMAs in the bottom portion of the box. So really the key is upper portion, the box is what you need more immediately. Lower portion is where we keep things like Surgi Lube, nipple adapters, an extra nipple adapter, an extra flow meter, and things along those lines. An extra, believe it or not, stylet, etc. So related equipment and sizing. So, endotracheal tubes, you guys are pretty solid on that. I will tell you that for females, kind of that lower right hand box there. So, females 7 to 8, this is rule of thumb, male 7.5 to 9. But LMA sizing on the left side, lower left, is something that therapists and exam candidates tend to be less familiar with. So what you really want to know is LMA sizing for small children and adults, be a 3. For adults, average size adults, a 4, and a large adult greater than 70 kilograms, a 5. 3, 4, and 5. I think there'll be a question related to that on there. Award about a video laryngoscope. So they're becoming the standard of care. That's the good news. And they're really good. We're showing you a McGrath device here in the lower right. But check the remaining battery life. The batteries last for 250 minutes with a McGrath at least. Some of them will actually even be rechargeable batteries. Bear in mind that if the distal end, I used to use a lot of Surgi lube on my tubes. If the distal end becomes, if you will, covered with Surgi lube or water-soluble jelly, you will not be able to see. So you may have to go to the old-fashioned way, use a video laryngoscope like direct laryngoscopy. That's more of a clinical issue than one you're gonna have to know for the ACCS exam. ET tube tip will not initially become visible, so it's going to be as you just got to kind of advance it. It takes a little bit getting used to these devices. May require more of a curve to the ET tube and may result in soft tissue injuries. The good news is they overall add an advantage in intubation. Okay. The bad news is, and it's not life-threatening, but again, because you're doing it indirectly, okay, there's more kind of minor soft tissue injuries that can be implicated. Key steps in the procedure, you guys should be okay with this, even if you don't intubate where you work or where you have worked. Confirm the indication, gather and set up the equipment, see the equipment slides, assess the degree of difficulty. We'll talk about that momentarily. Considering things like sedation, position the patient, pre-oxygenate, medicate if needed. Now, we're not going to medicate, but often they'll say, our drug of choice is typically Versed. And we typically will give anywhere from 2 or 3 to 5 as an initial dose, going up to 10 if need be. We are actually allowed to intubate rapid sequence if the attending physician is there only. Okay. Check, remove dentures, excessive secretions, insert the laryngoscope, sweep the tongue to the left, lift the epiglottis to visualize the glottis. Advance the ET tube through the oral pharynx, under the epiglottis, through the glottis. Everything is easy. If it goes this way, many times it does, but it's 80% of them are pretty straightforward, 10% and the final 10% can be pretty challenging. Inflate the cuff, connect manual resuscitate or ventilate, and then of course confirming your initial placement by having your end tidal adapter or your detection device available. Listening to bilateral breath sounds, chest X-ray. One of the indicators that's not good is if the tube is fogging, it's not a good indicator. I've heard therapists that have more experience than me, it's fogging, we're in. They're probably in, but it's not confirmed not to be a good indicator. Key points when assisting. So those are key points when you're actually doing it. Help ensure that all the supplies are there, help prepare the equipment, inserting the stylet, connecting the syringe, testing the cuff, having available one size smaller ET tube. So if you're intubating with an 8, have a 7.5 handy. When I say one size, half a size, but one size. Set up the end tidal cable, adapter, waveform, suction, and yank arrow, have it available and functioning. Position the patient. If you can't see, the first thing you do is if you go in and you can't see the glottis or the vocal cords, reposition the patient. Help ensure all supplies, equipment are situated near the intubator and functional. So they'll say, I'm going to pull the patient up. You have all the supplies on the patient's chest, you pull them up and they're going to be falling all over the place. So just be mindful of that. Having a bedside table right next to where you're working is a pretty good way to go. Or if you have a pillow there, maybe have some of it kind of wedged under the pillow as you pull the patient up. Apply cricoid pressure known as the Selleck maneuver, or prepare a smaller ET tube if you're having difficulty. Once the patient is intubated, inflate the cuff, confirm placement. Once placement is confirmed, secure the tube, manually ventilate the patient, set up the ventilator, lions and tigers, and recommend the chest X-ray, etc. Recognizing a difficult airway. This is something I guarantee is going to be on the exam. So a high Malin-Patty score, I have a separate slide on that, ranges from 1 to 4, 4 being the most difficult. Reported history of difficult intubation. History of multiple intubations and/or tracheostomy. So tracheostomy, they could have some scarring distal beneath the vocal cords. So those are cases where they have enough scarring, you may be able to get the tip through the cord. It doesn't want to advance beyond that. So you're just going to try to have to use some finesse, maybe a little bit more Surgilube, maybe a smaller size tube, maybe a little cricoid, etc. Chest X-ray examination, tortuous trachea, narrow upper airway or trachea. Ability to, to adequately sedate, or you're unable to do so. Okay, so ETOH, so alcohol withdrawal, other substance abuse withdrawal, upper airway trauma and or surgery. Quickie on the Mallampati, starting, the class 1 all the way to class 4. Notice with class 4, with size of the tongue, cheeks, etc. So just giving you a little bit of insight there. When my wife had her surgery, she had a partial knee replacement. The anesthesiologist had the same first name as me. His name was Albert. And he basically said to my wife, open your mouth. And he had looked at her and said, "Ma, you have a big mouth." And I was right next to her. And I you know what I did? I was a good husband. I said absolutely nothing. I just smiled and, whatever. But he was assessing, I'm being smart here, but he was assessing her Mallampati score. A little bit on x-rays here on the left-hand side with the white arrow, you have actually kind of a deviation in the trachea. On the right-hand side, you have a narrowing. So you don't always have the luxury of having this, but if you do, use it. And sometimes your chest x-rays will have some of this. So it's not even a neck x-ray. It's just, these are extreme examples. But sometimes if you have a chest x-ray, take a look at it and see if there's anything remarkable there. Special considerations for difficult airway, considering calling anesthesia, consider a rapid sequence intubation, whether you're doing it with the attending there or, just passing it off to a physician. Use a video laryngoscope in extreme cases where you can't intubate, can't ventilate. Bronch-assisted intubation, where you're actually having the bronchoscope there, you already have a ET tube that's threaded over it, etc. Alternative devices such as an LMA or an I-gel. And I'll talk about what an I-gel is in a little bit, but laryngeal mask airway is self-evident. We've talked about that. Specialized equipment such as a Bougie. I don't personally use them myself, but I'll show you a picture of a Bougie a little bit later on. But it's an introducer where gum Bougie, sometimes they're called, where it's a kind of the side a little bit thicker than a suction catheter, but when I say more rigid, kind of medium rigidity, where you can get it through, but you can it'll go through the cords more easily, and then you can thread your endotracheal tube through it. It also has a little bit of a hockey stick shape at the end to better facilitate tracheal intubation rather than esophageal, and to also help potentially feel the cartilaginous rings to help suggest that you're in the right place. Use cricoid pressure to optimize patient positioning. So, your patient's in bed, head, top of the bed in a sniffing position. Cricoid pressure is actually known as the Selleck maneuver, as I said, originally designed to help prevent aspiration if the patient vomits. For patients who maybe ate a half hour earlier, but they coded, and it would be a real good idea to use cricoid pressure, not just to visualize, but also to pinch off the esophagus and to minimize the chance of aspiration. If possible, leave oxygen cannula in place. So the latest over the past 5 years or so, whether it's a high flow or low flow nasal cannula, if it's not on your way, leave it there. It's going to buy you a little extra time with oxygenating the patient while you're attempting to intubate. Depending on where you work, use a difficult airway box. Kept in the adult units, fiber optic equipment, and things along those lines. A lot of hospitals are really starting to adopt that difficult airway initiative. Can't intubate, can't ventilate, it's a medical emergency. If repositioning the head and cricoid is not effective, get the difficult airway box. Use an adjunctive airway such as an LMA, bronch-assisted emergency cric kit in extreme circumstances. And this is really some of the elements of a difficult airway box. You can actually see the emergency cricoid thyrotomy kit. Both, you can actually see it on one side, and then we flip it over to see what's actually there. That device, that blue thing that's kind of U-shaped, it's really not U-shaped, it's straight. It's just U-shaped to fit in there, is in fact a gum Bougie. It's a gum Bougie. And this is ours, but there's different variants of a difficult airway box. On the right hand side is saying what's actually in there. Emergency cricoid thyrotomy kit, I-gel. So you actually an I-gel, by the way, I will actually show you 3, 4, and 5. An I-gel is like an LMA. but it's not, it's got gel on the end of it. I say gel, almost that same type of gel they use for some of the CPAP masks. That's very pliable. So the idea is you're not filling it with air, but because that gel is so pliable, it can form a nice seal, McGrath video laryngoscope, different disposable blades, a Bougie, decanto suction. I'll show you in a moment, but a decanto suction just has a bigger opening than a yank hour. You're able to even suction small particulate like food matter and that sort of thing. And then, of course, your sterile gloves. Your eye gels are just pictured here, your different sizes, but the idea is it's very similar to an LMA, except you're not inflating it. Sizing would be similar to what you'd have with an LMA 3, 4s, and 5s. A little bit on the Bougie. So again, Bougie can be used alone or it can be used as an introducer through, to introduce this through the vocal cords first, and then you threading the endotracheal tube right over it. Decanto just, looks a bit like a yank hour, but again, has a much bigger opening. Proper patient positioning, that's an alliteration, proper patient positioning, sniffing position, a little bit on what you're actually doing. This is, of course, provided the patient does not have a fixed, a neck injury or something that would preclude you from putting the patient in the sniffing position. Inserting the laryngoscope, insert it carefully, avoiding the teeth, sweep the tongue to the left, getting it out of the way there. So A, and then sweeping to the left, B. And this is a little cricoid, could go a long way here. The top here is showing you kind of a line diagram of where you'd actually do it. The bottom portion is showing you the visualization before A and after B, cricoid pressure. Confirming placement, auscultation of the lungs, and the abdomen. You want to hear good aeration in the lungs. You don't want to hear it in the abdomen. Fogging the ET tube is generally not a good means of verification, as I said. Confirmation gold standard is end-tidal CO2 with waveform. Color chain is an indicator. If waveform is not available, chest X-ray is also good. If confirmation is in doubt, deflate the cuff, extubate, manually ventilate. If able to manually ventilate, continue doing so. Maybe they need an artificial airway. Maybe you wait for the anesthesia to come. If not, quickly assess, address the cause. If more sedation is needed, you need to reposition. Do you need cricoid? Do you need some adjunctive device such as a bronchoscope? Reposition the head, apply cricoid, use a smaller ET tube. If readily available, consider fiber optic. Consider another approach, as I mentioned earlier. Some review questions, then we'll come down the home stretch. When attempting a physician-ordered elective intubation, you're unable to visualize the glottis after placing the patient in a sniffing position and properly inserting the laryngoscope. The patient saturation is 99%. Which of the following would be your next step? Reposition the patient's head, ask for cricoid, abort the attempt a blind intubation, call your supervisor for help. The last choice is ridiculous. Your supervisor's not even you don't even know who your supervisor is half the time, what they're doing. They're in a meeting half the time. Reposition the patient's head, ask for cricoid pressure. Remember, this patient sat is 99%. So they're telling you something. They're saying, okay, but the patient's stable, but you got to, keep proceeding here. Providing the attempt is not exceeded 15 to 30 seconds, and the patient's pulse oximetry has remained in acceptable range, it would be best to reposition the patient's head and neck, ask for cricoid to better visualize the glottis. Obviously, if that doesn't work, take it out, bag the patient up, either attempt again yourself or defer to someone who has more experience. What degree of difficulty for intubation would you expect a patient with a Mallampati score of 4? So that we said the most difficult, and we talked about it, know those scores, know that 1 is easy, 4 is most difficult, and 4 is associated with, again, maybe you're even deferring to anesthesia or doing a rapid sequence. Knowing your ET tube size for an adult male, 7.5 to 9. They're going to make this pretty readily apparent, but I think they're going to want you, I think this would be like part of a question, but not the whole thing. They definitely want you to know sizing of LMAs and ET tubes. Cold. So again, the range is 7.5 to 9 for a male and 7 to 8 for a female. What range of laryngeal mask airway is generally recommended for adult males? 4 to 5. Again, small adult, maybe 3, but 4 to 5. Keep in mind one other thing too. Just going back to the preceding slide on ET tubes. So if a patient needs to be bronchhed subsequently, 2 days later, a 7.0 versus a 7.5, in many cases, you can't use a standard bronchoscope on a 7 ET tube. And you'll have to maybe use a pediatric one, which won't also go as far. Okay, so it's even thinking ahead. It doesn't mean you can't use a 7 or you shouldn't use a 7. It's just there's a potentially big difference downstream when you consider that 10 or 20% of your patients that are on prolonged mechanical ventilation will need to be bronched in some manner. 5, which of the following is generally not contained in a difficult airway box? Bougie. Bougie very much is. Emergency cric kit. Nasal cannula. Multiple suction devices, including a decanto suction catheter. The content of a difficult airway box include Bougie, multiple alternative airways, emergency cric kit, and the like. One of the most reliable means of confirming successful intubation at the bedside is which of the following? Fogging, we said that's not, no. End-tidal CO2 with waveform, doesn't say end-tidal CO2, so far the best. Abdominal rise, nah. Pulse oximetry, nah. So this is, the explanation we can read, but it's pretty self-evident that end-tidal CO2 is the best of what's given. 7, when multiple unsuccessful intubation attempts have exceeded 30 to 60 seconds and the endotracheal tube placement has not been successful, best actions, which are the following? Resume manually ventilating the patient, 100% oxygen, couldn't call anesthesia. Call your supervisor. What we say about your supervisor? Supervisor will call your manager, will call your director, and they're all at the, in the mothership, in corporate. Continue trying to intubate, perform an emergency tracheostomy. When multiple unsuccessful intubation attempts have exceeded 30 to 60 seconds, it's generally best to resume manually ventilating the patient with 100% oxygen. Let another properly trained individual do it, most preferably an anesthesiologist. When assisting a physician with an endotracheal intubation, they indicate they think they saw the tip of the ET tube go through the glottis. However, you note that there is no end-tidal CO2 waveform. There is a prominent breath sounds over the epigastric, basically over the stomach. The SpO2 is dropping through the 80s. Patients getting harder to manually ventilate because their belly's filling up with air, pushing up the diaphragm, etc. What do? Oh my gosh. Recommend that a nasal gastric tube be inserted, maybe eventually. Call your supervisor. Recommend that the cuff be deflated, that the ET tube be removed, and that manual ventilating with 100% oxygen be reinitiated. Perform an emergency tracheostomy. Feedback. When in serious doubt, the ET tube is in the trachea and the patient appears to be decompensating, the most appropriate action is to immediately deflate the cuff, remove the ET tube, and resume manually ventilating the patient with 100% oxygen. Selected references, in particular, this Applebaum example. So it's 2022 American Society of Anesthesiologists Practice Guidelines for Management of a Difficult Airway. They talk about many things, including, leaving the oxygen device on the patient if you can, including a lot of these adjunctive, measures that we've spoken to here. So yet again, want to thank you guys for attending this session. Hopefully you learned something from it that will help enable you not just to be even better clinicians than you are, but also to pass the ACCS exam. Hopefully you come back to us again for more of your educational and CEU needs. And most importantly, have a great day. Thank you very much.